we'll begin again. All right. So we've got to now think about types of information we're going to process in the limbic system if we're going to think about using it for memory and context and sort of, to some extent, what we think about as emotional valence. Is this an experience? This is good? Is this bad? How do we want to respond? Because we do responses that are far more than just reflexive responses. So the only thing I would point out is that my disclosure hasn't changed, but many of you may have seen the news yesterday. Came out 7:15 in the morning yesterday that Biogen has taken its drug aducanumab, which is the drug that they pulled from a clinical trial for AD. They stopped the trial for what was felt to be futility. They've changed their mind, and they're going to try and take it to the FDA as the first novel therapeutic for Alzheimer's disease. So hopefully at some point there will be more direct data for me to have, even if it doesn't have any connection to the course content. So that's actually exciting. It's exciting. It's a little confusing, and I have not gotten a very clear, had not had a very non-lawyerly conversation with my contacts at Biogen yet, unfortunately. So we've got all of, as I was saying, we've got all of that sensory information. We've got it coming in not just from somatic sensory information from the body, but we've got it from vision. We've got it from smell. And as we'll see, there's an enormously close link between smell, memory, and emotional assessment of that. It's the power of olfaction. It is directly wired in lots of ways. And we know that these are going to be driving our eventual motor output. And we know that the pathway for all of these stimuli runs through, except for olfaction, runs through thalamus, on up to cortex. And when you get to cortex, you begin where? It's the major sort of types of inputs that you go to. What pattern of layering? Remember, there are, not what layer, but what's the cortical pattern going to look like? Yes, it'll be unimodal, and what does unimodal sensory cortex look like? What? It's granular cortex, okay? And it goes from unimodal to multimodal, and what does multimodal cortex look like? Yeah, homotypic, okay? And then as you go from those multimodal ones, you go to the sort of more higher level processing areas, your dorsolateral prefrontal, your orbitofrontal, and actually your cingulate along the way, which we haven't mentioned. And then from there, where do you head in order to get an output? Assuming your output is going to be somatic motor? Yeah, first you go to high-level motor planning, premotor cortex, motor cortex, and out down through your corticospinal tracts, out to your motor neurons to actually contract muscles, which is your way of affecting something. We haven't talked yet about how you go down to your autonomic outflow. Where's your autonomic outflow going to be? What levels? Brainstem and spinal cord, but where in cord? Autonomic, preganglionic, motor neurons sit where? Intermedial lateral. Where's the intermedial lateral? What levels? T1 on downwards. Okay? We haven't talked yet about what innervates them. We've talked a lot about what innervates anterior horns. Corticospinals, rubrospinals, vestibulospinals, right? Reticulospinals, all of those. Those are all going to the somatic motor anterior horn cells. We haven't talked yet about what goes to the intermedial lateral. And it's going to have to come down from above because it's part of that same contextualized response, okay? You may start to run and your heart rate is going to go up, okay? They're both driven by the same stimulus, okay? And we're going to have to figure out that path downward and figure out how it happens, all right? And we know that our motor system and our things that are motor-like, meaning the emotional components of motor, the prefrontal pieces, are modulated again by cerebellum via the thalamus, as well as by those basal ganglia circuitry loops that go cortex to a striatal component, to a pallidal subthalamic network that has both positive and negative loops, and then back regulatorily onto the thalamus and back to the cortex. And so we have all of that, and then I've sort of tucked the limbic over here because it is partially cortex and partially deep. Okay. So, limbic cortices. So the first to think about is what's here in the sort of bluish purple, and that is cingulate. Nicely named for you. Okay? What is sort of more, central than the cingulate, right beneath it? Corpus callosum. Okay? Notice the shape, because this shape is important. This arcing shape allows you to see these structures in two cuts often, so that I will be able to make a cut like this in the horizontal plane. I could make a straight one with a blade, and I would see corpus callosum and cingulate, corpus callosum and cingulate. Okay? So you can see them both. If we follow it around, we have an area that is down here that we might call the very anterior portion. Okay, here's when we talk about anterior cingulate, we usually are referring to this zone. Okay? And then further back, as you come around, there's this narrow little point, and it's actually not a separation. It's that faint color fade from purple to green, which is labeled as the isthmus. Okay? The narrow bridge. Okay? Think about that piece that holds the left side of the thyroid and the right side of the thyroid together. Okay? It's that narrow little bridge. And at that point, the gyrus is still continuous, but changes its name, and it's called parahippocampal. Okay? What does parahippocampal tell you? It's next to hippocampus. Can you see the hippocampus? No, it's rolled in under, and that's the piece of anatomy that we're going to try and sort of make clear later on in the morning. All right? So we've got this continuous structure, okay, running all the way around. What vascular territories will it be in? Well, let's start with the anterior portion of the cingulate. Anterior cingulate will be in anterior cerebral. Remember, they come up from the carotid, they come to the midline, they touch, and then they've been removed, but they run just like this, right along the anterior cingulate, just like that, fanning out, all like that. So basically, probably all the way back to about here is going to be anterior cerebral artery territory, right? It's going to carry the leg components of both motor and somatosensory cortices in its vascular bed. And then beyond it, what do we come to? Yeah, this is mostly going to be posterior cerebral territory, all the way back to here. Some portion up here is going to probably be what? Yeah, it's going to be middle, as the middle cerebral goes out the Sylvian fissure and gives branches right there. Okay? But most of this is going to be in either posterior cerebral territory or anterior. Okay? And then there's this small little region down here known as the subcallosal area. Makes sense. It's right below the callosum. Okay? So, when we think about it, we think about the cingulate and the parahippocampal gyrus as what was called the limbic lobe. It's the counterpart to the frontal, parietal, temporal, and occipital lobes, named by Broca. And it's the hem. It's that edge of the cortex. If you unfold the rest of the cortex, you have a completely contiguous sheet. Okay? And as you'll see later, that cingulate and the parahippocampal gyrus form the two ends. Okay? We have the amygdala and the hippocampus that we will see, and then we're going to have parts of basal ganglia that are wired to these. The same way other cortical areas are wired, especially frontal and up to the all of the frontal lobe is wired to basal ganglia, either motor components, premotor components, IM components, frontal, orbitofrontal components. Those are all wired to through basal ganglia. So is the cingulate. Okay. Parietal has much less connection through basal ganglia because it's mostly not determined with gating output, but rather handling input. Okay? And then we've got a series of associated structures. We've got mammillary bodies, which are a major hippocampal output target. They are part of hypothalamus, but we'll talk about them today because they're a target on the output. We've got the olfactory bulbs, which project in, because they bring that olfactory information. And then there are a couple of other important structures. The substantia innominata, which is a cholinergic structure, which is tightly wired in, and these various brainstem nuclei, including ventral tegmental area as well, that are really part of the sort of regulatory components here for this. And we'll discuss those in the context of hypothalamus on Friday and then the diffuse systems on Monday. So it's really hard to sort of integrate this all the way, but I just at least wanted to anticipate slightly. So when we look at this, and this is the paper of Broca's where he named it, what he realized was that if you go out the convexity from this edge, and you come up along the medial surface, do you have cortex continuously? You can unfold it. You go around the lateral aspect, you come to the Sylvian fissure, do you have cortex continuing? Yes, you go down through the operculum and along the insula. You come out the insula along the temporal operculum, and then you come around the temporal lobe, and you come back up, and look, you're at the edge again. It really is the edge. If you unfolded that cortex into a flat sheet, this would be the binding edge all the way around. And so you should really be able to try and visualize that expanded unfoldedness in your head. When we look at it in the brain, not from that medial aspect, it's really hard to see much of it from the basal surface. But we do see some. So we've cut across the midbrain. So we can see, if we looked at it, what would we see? What vessel would be running right here? Yeah, I heard the initials mentioned. Posterior cerebral, right? Wrapping around, coming off the top of the basilar, first the P1, then the P2 segment, differentiated by the entry point to the posterior communicator. Okay? And here they are, and that's why this is all in the territory of the posterior cerebral. And it's why the middle cerebral that's running out this way is going to actually give rise to this very anterior tip territory. Okay? And what you see is the uncus, the anterior-most end. Remember we talked about uncinate herniation as you push one side across the tentorium? That's the portion you put across the tentorium. And then we've got the rest of the parahippocampal gyrus coming back, and you can usually just about see the isthmus as you peek backwards. What's this right here? Too bad. Let's go back and look at this picture here. You're looking in from the bottom, you're looking just past the isthmus, and you can see something crossing the midline. What is it? It's the corpus callosum, okay? When you look at those brains, actually nobody has an intact brain left in lab because I cut them all in half, right? But when you look at that side, you should be able to see that inferior posterior edge of the corpus callosum back there. All right, so now that cingulate, or rather, the hippocampus is tucked in underneath. So this is looking at the medial surface, deep to, here's the uncus here, and the parahippocampal gyrus, and then deep to it is the hippocampus. It has this little trail of gray matter that runs up along the surface of the corpus callosum. Those of you who work in rodents know that there are some sections where you see both a dorsal and ventral part of the hippocampus when you cut a coronal section. Okay? It is curved, and that's because the hippocampus in the rodent doesn't have anywhere near this much brain to develop here, and so it's effectively sitting like that. And you can get a coronal section through a rat or a mouse brain and see the hippocampus twice. In humans, this huge growth of prefrontal cortex has pushed it all the way around to the temporal lobe. The consequence is that it actually leaves behind this tiny little thin trail of gray matter. And we can actually see that under the microscope, but it's known as the inducium griseum. Okay? And it's the remaining corresponding part. So when you read animal papers, people will sometimes talk about dorsal hippocampus. And this is what they are referring to. For us, all of dorsal and ventral are in the same structure. They are anterior versus posterior, and there's somewhat degrees of difference in their functionality that we'll touch on later in the morning. So where are these structures? So which of them can you see here? Any of them? Well, if this is the... So on the medial surface, the gyrus immediately above it will be cingulate. So here's my cingulate. Notice these vessels right here in the subarachnoid space. Those are actually branches of anterior cerebral artery. What else can you see? What are these branches of? Yeah, those are branches of middle cerebral artery. How about these? Yeah, you got anterior, you got middle. So is this posterior? Where's the posterior cerebral come from? Comes off the top of the basilar. How far away from the basilar are we? Miles, right? I mean, there's 150 neuroanatomy questions between here and where the basilar is. Okay? Okay? So it can't be the basilar. What is it actually? It's anterior cerebral. Remember, the anterior cerebral, they all begin on the basal surface. The anterior cerebral comes around the anteriormost pole of the corpus callosum and then runs dorsal to it. So these and these are branches of anterior cerebral. And they're bigger here because this is closer to the origin, in fact. Which direction have we moved? Posterior. So, do we still have cingulate? Are we behind the cingulate? No. So where do we find the cingulate? Yeah, same place. This is one of those pretty easy ones, right? Doesn't move much. There's the cingulate. What else do we see now? What's over here? Medialmost surface of the anterior temporal lobe, right next to the, what are these? Yeah, so we're right next to the cerebral peduncle. So if I hop back to here, we're right next to the cerebral peduncle. And we look at the most medial portion of temporal lobe. What is that? Yes, parahippocampal gyrus. Right there. And right there. And then what is this going to be right next to it? That's going to be the hippocampus. That's what makes it parahippocampal. Now, you can see that the hippocampus doesn't look like cortex. It's actually folded in a different way. It has layers. Is it on the surface? Yes. So it meets the criteria to be a cortical structure. So there's hippocampal cortex. We can see a couple of other things that we're going to need to worry about here. What's this? Optic tract. How about these guys? 1, 2. Yeah, those are the mammillary bodies. In fact, these are going to be the fibers coming into the mammillary bodies. Here's corpus callosum. Anybody know what this is down here? Right at what structure? So I'm drawing in dotted lines that connect what? What is this? Lateral ventricle with the third. So this is the foramen of Monroe. And what is this? That's the fornix. So a left and a right there. And they are dangling down from the corpus callosum by the septum pellucidum. Okay? So here is our cingulate gyrus, and we've got our hippocampus now. Which direction did I move? Posterior, yeah. So these are all pretty much in order. They aren't always going to be in order. So where's the cingulate? Same place. Here's the cingulate on either side. Okay? What's this? Parahippocampal gyrus. That makes this hippocampus in there. This is peduncle. This is subthalamic. The white matter on the ventral surface is the ansa. The white matter on the dorsal surface is lenticular fasciculus. Okay? This is, I mean, we could spend an hour. Okay? Pallidum, what part? Interna or externa? Externa. On this side, we've got a little bit of interna here and a little externa there, and this is putamen. This is anterior nucleus of thalamus, caudate, insula. Notice, all the way around, from the cingulate gyrus, cortical ribbon, cortical ribbon, cortical ribbon, cortical ribbon, all the way through the insula, back to the operculum, torn here, so it ruins my story. But all the way around to the other edge, and you're back in that parahippocampal gyrus.
Could you say again what's this above the row?
So the subthalamic nucleus, remember, has the two fiber bundles that are leaving GPI. It has the fibers that run on the dorsal surface, which is lenticular fasciculus, and the ones that run that make the odd loop that come around, that is the ansa lenticularis. All right. Direction. I need to scramble these up next time. Yeah, I moved more posteriorly. Okay, so what have we got? This is cingulate. Parahippocampal. Tucked in beneath here is the hippocampus. This is the, right there? Yeah, LGN. And when we often look at sections of hippocampus, this is what we refer to as the canonical level. This is the level where the anatomy always looks the same if you are at the level of the lateral geniculate and the coronal plane. Okay? What's next to the lateral geniculate right here? Medial geniculate. What's this? Crossing the midline? Anterior commissure. Are we anterior enough to be the anterior commissure? Where does the anterior commissure cross? First of all, who does the anterior commissure carry? Temporal lobes. It's going to gather it from the whole temporal lobe, and in fact gathers it anteriorly. So are we in the anterior portion of the temporal lobe? No, we're like way back, right? We're way behind the midbrain, okay? Because we're at the geniculates, okay? We're back there at the posterior level of the thalamus. So this can't be anterior commissure, so it should be posterior commissure. What's traveling in it? Those reciprocal connections that are associated with pupillary light reflex. Where are we? What level of thalamus have we got? Pulvinar. We have, really boring, we have cingulate. We have parahippocampal gyrus. We have hippocampus. We have caudate. Exactly. We have, can't see it well on this side, but right over here. Yeah, tail of the caudate. All right. So when we think about the hippocampus, as you follow its shape, it's got a big bulge anteriorly. It tapers and takes on a uniform shape as you move posteriorly, and it's gradually going to taper out as you come back to about the level of the atrium of the lateral ventricle. Okay? Along the way, okay, we've got the along the way, the structure is basically gathering output fibers. So the way to think about the hippocampus is that it is made up, sort of in a sense like the spinal cord, of a series of discs. Things come in and are processed in each disc level, and the output from it is going to join and run on the surface. So anything that is coming out is going to join and run on the surface and run posteriorly. So that as you move posteriorly, what should happen to that white matter bundle? It's going to get bigger. Why? You add to it. It's sort of like the dorsal columns. As you come up the cord, the dorsal columns grow in size because you keep accruing more fibers, right? Okay. You get to the end of the hippocampus, and now all you've got are your output fibers. And what those do is loop around and run more anteriorly to their synaptic target. So they're going to make this funny loop. Okay. The way this runs is what's drawn here is this gray structure here, is the fornix. Means bridge, okay? Or arch of the bridge, okay? So the fornix runs anteriorly, and it has gathered all of the output. It comes off of it, and it has what's known as the foot, the crus, okay? The place where it starts. It arches forward, and it comes forward, and then what is this little mustache crossing the midline? Anterior commissure. What is around the hippocampus anteriorly right here? Anterior temporal lobe, right? think that anterior parahippocampal gyrus, the anterior parahippocampus, the uncus is right by the anterior temporal lobe. The anterior portion of hippocampus is right in front of it, so that's where the anterior temporal lobe is. So this is the anterior commissure coming across, and as you come to it, the fornix fibers are going to split, and they're going to have some that go in front of the commissure and some that go behind the commissure. And if you look, here's the hippocampus, and you can see this growing bundle of white matter on the surface, and that bundle that sits on the surface is known as the fimbria, and at the end, the fimbria, when it turns around, becomes known as the fornix. So here's the fimbria turning around to become the fornix. Fimbria coming off, turning around, becoming the fornix. The ones that come in front of the commissure get known as the precommissural fibers, and the ones behind it are the postcommissural fibers. Okay? So now you can visualize the hippocampus as those stack of discs, the white matter being built to have exiting fibers, making a loop and coming forward. Okay? When you look at it, it's slightly hard to visualize, and it's a difficult dissection, but I'll try and give you the sense of what's going on here. Here's the hippocampal formation. Okay? Here's the accruing bundle of the white matter. And then we're looking deep into the brain. So superior is deep into the screen. And those fibers arch away from us. They rise, go forward, curve downwards, and then as they get to the anterior commissure, some keep going anterior. Those are the ones in the precommissural. And the posterior commissure fibers are going to really sort of create that same arc and head backwards. And they're going to head to their target, which is mammillary bodies, drawn down here, right there. So if you look at it in this plane, which is slightly easier to understand, the top of the brain has been cut away. Hippocampus, fibers growing on the surface here as the fimbria, turning into the fornix, coming forward to the anterior commissure fibers here that are connecting temporal lobe and temporal lobe. Okay? Some are shown here going behind it, and those are the ones that are the most common ones. And they go behind it, and they come back down here to the mammillary body. Okay? So we've got this loop that goes like this. So this is going to be a synapse, a fiber that starts here, arches around, goes like that, back, and synapses here. Okay? Can we see them? Can we see those fibers? Well, where are they? So here is the very anterior-most portion of hippocampus right here. This is the uncus right here. Okay? This is the fornix. Okay? So at this point, we are making that cut right at the front end, right here. You've got the anterior piece of hippocampus, and you've got the fornix. Okay? Down here, these are the mammillary bodies, and those are the targets of that. You can actually see some of those fibers right here coming in. Which direction have I moved? Give you a hint. I'm being really fair in lecture. Okay, I moved posterior. Okay, so now what do we see? This is parahippocampal gyrus. This is hippocampus. See this white matter starting to build on the surface here? That's the beginning of the outflow fibers. How about these? What's this? Look, anterior commissure should be running which way? Yeah, should be running, and we can actually see the anterior commissure. So this is what lobe? This is? So we have to find white matter that's going to connect from here to here. And in fact, we've got part of anterior commissure here and part of anterior commissure here. Remember, the anterior commissure makes an arc, and it moves anteriorly as it moves to the midline. So here we're not at the most anterior portion of it, right? Because we can see those sort of lateral wings of that mustache out slightly more posteriorly. So now here I've got these two fiber bundles coming down, heading to the mammillary bodies. Those are the fornix. And are these precommissural or postcommissural? They're postcommissural. We know that because we see them. First of all, we see them heading to the mammillary bodies. Those are postcommissural. But we know that we are behind the level where the anterior commissure crosses the midline. Okay? So the anterior commissure would be tucked in here if the brain were intact, and you'd see it crossing as it went like that. Okay. If the rest of the brain were still there, you would be able to see it because its cross is actually in that third ventricle. So the way it does it is the fornices come down, and the anterior commissure is mostly sitting in front of it. You can't see the fibers that run in front because they're buried in brain, whereas the fibers that come behind are still separate in the ventricle, so you can actually see them. And when they come down like this and you see them in, and this is the hypothalamus that we will talk about on Friday, we call them the pillars of the fornix. Okay. Yep. Right here, that's the third ventricle. Okay? So these are inside, deep in from the third ventricle. Okay. What do you see here? Different person. First hint. So one of the lovely things about brain is that with the exception of about 3 structures, everything is paired. Okay? Which allows you to compare left and right and say, do they look the same? So what doesn't look the same? Yeah, so there's something wrong with the right mammillary body. And if the mammillary body is strong, what do you know should be projecting to the right mammillary body? Right hippocampus via the right fornix. How about the right fornix? Does it look okay? No, look at that. So here's the left fornix. It's a pretty respectable volume. Here's the right fornix. It's like small. It's not the right color. Now go back and look at the hippocampus. The hippocampi look the same? Well, we're not at the sort of canonical level, so it's a little tricky. But when you look here, you can see the white matter on the surface, the nice gray matter layer, another white matter bun, nice gray matter. You look at this one, it just doesn't look right. And if we actually move, this is a normal here. Oop, I thought I had the other. Here we are. This is another patient with the same process, in fact, involving the same side of the brain. So this is now roughly at the canonical level of the hippocampus, right? Because you can see the lateral geniculate. So first thing is that my fellow who took this picture did not do one of the critical things, which is wipe all the little spots of blood off. So all those little spots of blood are not real. They should just have been cleaned up before you took the picture. You can't fix that with Photoshop, unfortunately. But what do you notice about the hippocampi? We're at the same level of the brain on the two sides, so it's not about how the cut was made. But the one on the right is much smaller. It's flatter. It doesn't have that sort of nice round contour. Okay? And then look at the fornices. Smaller. And this is hippocampal sclerosis. So in the setting of temporal lobe epilepsy, the hippocampus both is a source of epilepsy, is an easily made epileptogenic structure, and in the setting of epilepsy, it undergoes neuronal loss from excitotoxic injury, mostly, and that makes it both smaller and more epileptogenic. Okay? And so this is hippocampal sclerosis. This is a finding in somebody who died sudden death, SUDEP, sudden unexplained death in epilepsy. But it is people like this, among others, who are good candidates for surgical treatment of epilepsy by resection of that hippocampus. And the problem is that this is a feed-forward process. The more you seize from it, the more likely you are to have future seizures because the continued ongoing injury in the hippocampus makes it more and more epileptogenic. All right, one or two more little bits of pathology. What do you notice in this person? And here the symmetry may not help you as much. It does a little bit if you look at the panel over here. What do you see? Look anywhere in the brain. Well, let's look in the frontal lobes. Compare the frontal lobes on this side here. This one with this one. So, yeah, there's something wrong with the white matter on which side? Yeah, texture looks horrible, doesn't it? It's sort of crumbly and cavitated and not look good looking. How about the cortex over it? Gray matter looks weird. There are places where you lose it. Okay? So is this just somebody who's got like a cortical defect here? I mean, here on this side I can follow the cortical ribbon. Here, I sort of lose it up here. I can't tell what's gray and white. I can't tell what's gray and white. Here maybe it's sort of fuzzy down. Temporal lobe looks okay. So what do we think's going on here? Does this look normal sized? How about the corpus callosum? You ever see a corpus callosum look that fat? No. This is somebody with high-grade glioma. This is a brain tumor infiltrating that entire hemisphere in the frontal lobe and crossing the corpus callosum. But where else is there tumor? Let's look over here. So here you can actually see. Look at how fat that corpus callosum is. But what else has got tumor in it? Fornix. So if you have tumor in the fornix and you follow it back, where might you find tumor? Here's just a close-up look at that. Where might you find it? Hippocampus. And here, this is the posterior hippocampus right here. This is that posterior portion of the fimbria about to turn around. And on this side, the whole thing is infiltrated by tumor, but it hasn't crept back. But on this side, here's the beginnings and origins of the fornix. It's massively expanded here, and it crawls all the way back. And look, on this side, the hippocampus is infiltrated too. Just like those cortical areas in the frontal lobe, here the tumor has infiltrated hippocampus, and you can't see its markings. But it's following an anatomic path. It's highlighting for us the fornix and its projection back into the hippocampus. Okay? So when we think about hippocampus, this is one of the few times, like cerebellum, where we actually have to think about not just gross, but microscopic anatomy. Because its structure and function are not sort of global at the whole level and not separated out where I can say, like, there's caudate putamen versus pallidum, but rather distinct neuronal layers within it. It's sort of like cortex. It's a layered structure. Okay? And it is folded in on itself. So this would be what? Parahippocampal gyrus. This is that medial surface. Here's the hippocampus tucked in underneath. Okay? Right here, this is the building white matter bundle of the fimbria, right there. And the white matter that's entering it is coming from the white matter that sits right on the surface here that's known as the alveus. So these are names you need to start to know. Alveus and the fimbria. Okay? And then we've got, this is a neuronal stained section. So here you can see layered cortex. And as we come in, we've basically got this layer of neurons and then a second very densely packed layer of neurons. So you look at that nice densely packed layer of neurons here, and what name would immediately jump to mind? Well, nothing that would make any sense, but it's called the dentate. Does it look like the cerebellar dentate? No. What does the cerebellar dentate look most like? The inferior olive. Does the inferior olive look anything like the superior olive? No. Okay, so there's no way I can explain it. It's called the dentate. It is made up of little cells. So what are those little cells called? Dentate gyrus cells. Okay? It's the dentate gyrus granular cells. Okay? They are granular cells. And these are, for the most part, big cells with a triangular cell body, apical dendrites, and projecting out axons. And they are, therefore, pyramidal cells. So those are the hippocampal pyramidal cells. They are segmented out, and this was done by Cajal with his beautiful drawings, into the portion that sits enwrapped by the dentate gyrus, which we call CA4. And then based on the packing of them, we have the segment that comes to sort of CA3, 2, probably 2-1 boundary is further over here, and around to CA1, and then the transition into this zone here that is known as the subiculum. So, subiculum, dentate CA4, 3, 2, 1. Okay? Ca cornu amon, ram's horn. It's what Cajal thought it looked like as it curled up on itself. Okay? Now, how does this happen developmentally? Remember, we begin with a sheet. And so basically, this folds in on itself. And so the pattern of informational organization, in a sense, is going to be dependent on that sheet. So it begins with what is going to become dentate gyrus all the way deep. What is hippocampus, subiculum, and parahippocampal? It folds once, and then it tucks its head in underneath like that. Okay? So what does hippocampus mean? Hippo, hippodrome, hippopotamus. Okay, so hippodrome is the horse racing station. Hippo is the Greek prefix for horse. A hippopotamus is a river horse. Okay, and what is hippocampus? So hippocampus is a horse, is a sea monster horse. Okay, so this is the hippocampus. If any of you were particularly observant today, whoop, oh, no, I thought I had my slide in there. Never mind. This is the hippocampus as it sits operationally. So here is your ability to see the seahorse. Here it is like that. So you can think about the body of the hippocampus here being that subiculum and to the entorhinal cortex, and this is the fornix at its snout. How have I rotated it? Where's the medial surface here? Well, normally I draw the medial surface on the left, but remember, where does the medial, which of these structures sits on the medial surface visible from the medial aspect of the brain? What do you look at when you look? Do you see hippocampus? No, it's tucked in underneath. What do you see from that medial surface? You see the uncus, you see the parahippocampal gyrus. That's this right here. Okay? So this is medial. Okay? This is superior, this is inferior, and this is lateral out there. Okay? So, John.
So in this picture, where does it sort of kind of rotate back? I keep thinking about it as a sort of like almost like curved thing that goes into the fornix. And when we do this,
This is perpendicular. So this is a cross section of it. Okay, so think about this the same way you think about the spinal cord. Okay? In the spinal cord, you've got every single cross-section has dorsal horns, anterior horns. If it's at the right level, it's got intermediolateral horns. It's got the dorsal columns. It's got lateral funiculus. It's got anterior funiculus. It's got all of that structure. As you move down it and up it, white matter bundles change in size. Okay? But in any cross-section, you can conceptually think of it the same way. Hippocampus is like that. In any cross-section, you've got this. As you move through different levels of it, you will basically have comparable levels that don't crosstalk much with each other. But as you move more posteriorly along that whole body of the hippocampus, you're accumulating exiting fibers so that the fimbria will grow. And when you're done with hippocampus, you turn into the fornix, flips over and runs anteriorly, superiorly, and then eventually inferiorly to get down to the mammillary bodies. And so the circuit that we're going to talk about is the one that comes from entorhinal cortex. And these are numbered in terms of the order of synapses. So here is entorhinal cortex, which sits on the uncus. And where is the uncus? What gyrus? Parahippocampal gyrus. What portion of it? Anterior. Okay? And from there, we have neurons that project to the dentate gyrus. That's what this is. Okay? So we go entorhinal to the dentate. This fiber bundle runs right across the other structures. Because remember, this is not to the immediately next thing, but it's what's been folded all the way in and was at the tip when we were thinking about it here. Okay? So we're actually going from parahippocampal gyrus, essentially a fiber bundle that's going to, well, it's not going to run across the ventricle, but it's doing this, okay? And because it runs across and through the other structures, it is known as the perforant path. Then we have fibers that project from, and we're going to simplify it, so we almost always do things in terms of CA3 and CA1. CA4 functions a lot like CA3, probably subtle important differences for physiology, but for our purposes equivalent. And CA2 functions a lot like CA1. Again, subtle differences if you're a physiologist and a behaviorist, but for our purposes equivalent. We then have got a fiber bundle that is going to project from dentate gyrus to CA3, from CA3 to CA1, from CA1 to the subiculum, and from the subiculum out. And out means via the fornix, with targets including mammillary bodies. Some of these other fiber bundles get named. There's a paucity of imagination. Okay? So, these, unfortunately, are known as mossy fibers. It is really horrible. There's dentate in the hippocampus and in the cerebellum. There are mossy fibers in the hippocampus and in the cerebellum. They bear no relationship to one another. Okay? These mossy fibers turn out to be very rich in zinc. It's easy to stain them. It's easy to show when they're degenerating. They're useful for a lot of tricks. And then we have got the fibers that run from CA3 to CA1, CA1 to the subiculum, and then our output bundles. Okay? So we've got a circuit. Okay? So if we think about it, we can begin with the, sorry about that. Begin with the fibers that come in, and these are these blue fibers here coming in as the perforant path from the parahippocampal gyrus. We go from the dentate to CA3. We go from CA3 around to CA1, and CA1 out to the subiculum and out. So we begin deep in the dentate and work our way neighbor to neighbor to neighbor. So if you think about the developmental sequence, this is parahippocampal, subiculum, CA1, 2, 3, 4, dentate. That's the way the sheet develops. The way the information flows is like this, and then here to here to here and out. Okay? So it's not the same as the way we organize cerebral cortex. Okay? In cerebral cortex, imagine visual information. It comes into Brodmann area 17, where it then which is essentially an oval, surrounded by an oval, and then out here you'll start to separate. So some types will go this way and others will go that way. But most of your initial processing is right adjacent cortical regions. Here it's not. You skip to the other end and then you work your way back. So when we think about this, we begin in the entorhinal cortex. Oop. Sorry. I never remember which of these are the animated ones. So the entorhinal cortex via the perforant path goes to the dentate. The mossy fibers go to CA3. The so-called Schaefer collaterals go to CA1 on the ipsilateral side. There are some fibers that cross to the other hippocampus. So our hippocampi do talk to each other a bit, but mostly the bulk of communication is within one side. And those that are going to go to CA1 on the contralateral side through what's known as the hippocampal commissure. That's basically weaving of fibers between the two fornices. From CA1, they go to the subiculum. They do send some fibers into the alveus. The alveus is the white matter on the surface. As that peels off, it becomes the fimbria, and when we're done with the hippocampus, it becomes the fornix. So, so that's perforant path, mossy fiber, Schaefer collateral, subicular fibers, and out in both directions. And this, arcing around, is the fornix. All right. So hippocampal pyramidal cells are unfortunate in their fate in that they are relatively sensitive to hypoxic ischemic injury. They're just about the most vulnerable neurons. Okay? As a consequence, in the setting of hypoxic ischemic injury, slight delay after cardiac arrest before establishment of CPR, poor oxygenation in the setting of adequate CPR and circulation, these neurons die. And as we'll see, loss of those neurons makes people amnestic. Okay? This got recent publicity because it was described by people who should have known better and editors who definitely should have known better as being a novel finding, which is in the setting of opiate overdose, people become hypoxic. And people can be reversed from that with Narcan. And so there was a whole series of people who had isolated hippocampal pyramidal neuron, hypoxic ischemic injury, from which they became amnestic. And you can see it as this very bright signal on diffusion-weighted imaging here, dark on this on the average diffusivity map and all. And this was described as a very novel, specific finding associated with opioid abuse, opioid overdose. It isn't in any way. Okay, this is this was described, in fact, in the early 20th century by some as being the most vulnerable area. CA1 also carries the name Summers sector because he described it in the setting of hypoxic ischemic injury, and not with MR, but with histology. He described it then, and it's been well known for, close to a century at that point. All right. So let's talk a little bit about outflow and loops. Boy, I'm slow today. So that fornix is the output device for hippocampus. Okay? It mostly derives, in fact, from the subicular neurons and a little bit from CA1. Okay? Most of the other neurons in the hippocampal formation don't talk to the outside world. They are internal connections. Okay? All of the fibers that go to the post-commissural targets come from subiculum to my level of teaching. Okay? The ones that go pre-commissural are a mixture of subicular and CA1. Okay? So where are those fibers coming from? Well, remember, we've got a pyramidal cell with a axon coming out and a huge apical dendrite. The hippocampal connections go onto those apical dendrites on one side of the cell body, and the outputs come on the other. So that as you go from output of one neuron, it will have to get to the apical dendrite area of the other. Okay? So that as you come here from the output axon here, you see that it has to get from being on the basal surface of the hippocampal structures to the apical side to get to the next target, here a CA1 pyramidal cell, and then its axon runs like this. If it's going to do the same thing into the subiculum, it has to come up to the apical dendrites, and those axons project outward. If we look at hippocampus, it's pretty hard grossly to see it. Because it's based on neuronal packing. If I had to sketch it in, I would roughly say this is the dentate tucked in there. You can usually see a little bit of the white line. Here's our dentate, CA4, CA3, 2, 1, subiculum, entorhinal cortex. It's important because different diseases affect different areas, and so people are trying to develop methodologies for segmenting them out on imaging right now. Are we at the correct level? What's this? Lateral geniculate. What's this? Medial geniculate. What's this? Yeah, tail of the caudate. Here's tail of the caudate on that side. This is caudate. Okay? Fornix. Posterior commissure. What are these? What vessel? MCA branches. This is PCA branches. These are anterior cerebral artery branches. Okay? All right, this is just, I can skip this. I think I've said this enough times. Okay? These are the structures we need to think about within hippocampus. But when we think about what's going on outside of hippocampus, we need to think about where that information is going. Okay? So, here in blue are our output fibers, and here the hippocampus has been sort of unfolded. So this would be dentate, receiving the perforant path in green, going to CA, going through the pyramidal cell layers, and then these neurons here in blue are output neurons from subiculum and CA1. Okay? They leave and make this loop through the fornix, split at the anterior commissure, and the ones that are going postcommissurally come back here to the mammillary body. We'll talk on Friday about the ones that go anteriorly, which come to nucleus accumbens. What is accumbens part of? It's part of basal ganglia. It's part of striatum. Okay, and then the septal area that sits right here. Okay? So we come to the mammillary body, the hippocampal formation through the fornix to the mammillary body. Mammillary body projects out through a adequately named structure, the mammillothalamic tract. Okay? Where does it go? Thalamus. For a change, something is named in a way that you can figure something out. Okay? And it goes, in fact, to the anterior nucleus of the thalamus. A week ago, where does the anterior nucleus of the thalamus go to? Cingulate gyrus. And what's the cingulate gyrus connected to? Goes all the way around to the parahippocampoid gyrus. And in fact, the white matter bundle underneath the cingulate, which I realize I didn't say the word of, is the cingulum. I think I've got this, the cingulate. And the cingulum, that white matter bundle that runs with the cingulate gyrus, projects back to the entorhinal cortex. We have a loop. Loops are useful, but loops are also only useful if they, in fact, are not closed loops isolated from the rest of the world. So where are the points where this might talk to the rest of the world? Where do you think? Well, that's talking to the other side. That doesn't give you all... That's the other side, but it does. But memory isn't really left versus right, so you're not going to get a lot of new information there. So how about cingulate? What is it? Cerebral cortex, right? Likely to talk to other areas of cerebral cortex? Yeah. Okay. It's not just an isolated piece of cerebral cortex. Is there any piece of cerebral cortex that doesn't talk to some other cerebral cortex? No. I mean, that's its basic function. It has to talk to other cortical areas. So it's the interaction of cingulate with other cortical areas that basically is in and out that makes this not just a simple closed loop that's reverberatory. Okay? So back to the entorhinal. And in fact, back through the perforant path and on in. And this was proposed to underlie emotional behavior by Papes, who was a neuroanatomist. This is him at the Cornell Brain Collection. It's hard to see how he learned much since most of them haven't been cut. They're just sitting there intact. But it is, it's old, and it's a concept that you should know the name of, even though it is mostly, or it is significantly outdated in terms of its functionality, because it just said that this was a closed loop, and you can't actually do anything useful with a closed loop. Okay? It's hard to put anything into it. It's hard to get anything out of it. And we know that we make use of hippocampus for other functions. So let us take the break. Pick up again at 1:15, and I will try and pick the pace up a bit. All right, so I'm back. So I want to talk briefly now about hippocampus and its function, because it's really important. It's used in it's used experimentally. And did you have a lecture on, who gave the lecture on LTP? Was it Chin-Fei Chen? No? Did Jeff do it himself? Jeff gave it? Okay. So, I mean, it's the classic model for what we call learning and memory. Okay? It's basically, how do you use electrical... So in a sense, what would you think is a definition of memory or learning? Have you learned anything? Yeah. All right. So a response, so the acquisition of a response to some sort of stimulus, okay? Is that different than the patellar reflex? Why? It's plastic. So it's something that changes in response to activity. In response to various conditions, inputs, outputs, responses, and consequences, the synaptic function is going to change. So it's a change in synaptic function based on activity, okay? So the reason that LTP is used as the model of learning and memory is that it is an example where, based on the patterns of inputs that you provide, you change the strength of a connection, okay? And this is essentially the counterpart of what's called the Hebbian model, named for Donald Hebb, who basically proposed that the way learning happened was that some synaptic connections based on repeated activity, usually of two inputs, change their strength and become dominant. And that's why you go from having no response to the input to a consistent response to the input. John?
This might be a good question, but I'm thinking of like muscle memory and like how the cerebellum. So is it all like?
So we will get to that.
Okay.
That's because that, in fact, is not memory at all. That's a completely different type of learning. No, it's important. And in fact, when we think about it, we break memory down in a bunch of ways. And through studying hippocampus in patients with hippocampal lesions, we actually learn an enormous amount about the way memory is organized. So we think about memory in two basic categories, declarative and procedural. So that muscle memory, the ability, it's like riding a bike, okay? That ability to do motor activities that you have previously trained on is not memory. That's what we call procedural memory. It's not encoded and handled in the same way. Declarative memory, we separate out into two basic categories, semantic and episodic. Episodic is knowing the answer to, what did you have for dinner yesterday? Okay? It is about an episode that happened. It could be, what did you have for dinner yesterday? It could be, where was your 5-year-old birthday party? But it is about a specific event, as opposed to semantic, which is, what's an apple? Okay? I'm not asking you what's the first time you saw an apple. When was the last time you ate an apple? Okay? Did you like it's rather, what is an apple? And that's semantic memory. Okay? Facts not linked to context, as opposed to events that are evident, episode or space or place or individual specific. Okay? Those are very different than procedural memory. And I just happened to have come across this cartoon yesterday, and it's really this panel here that gets at the complete content here and answers John's question, because motor memories are stored as implicit memory, not declarative memory. Okay? Trying to use your conscious brain for motor tasks is basically accessing the wrong database. Okay? And it's really accurate. Okay? What you are doing is not using your input, storage, and retrieval devices the same way you are for either apple or dinner last night. So in order to understand this, I want to introduce you to this gentleman, HM. So in the 40s, he at age 9 fell off his bike. He was unconscious supposedly for about 5 minutes. He had a seizure at around age 10, generalized seizures beginning by the time he was starting high school. He also had a family history of seizures. He graduated from high school slightly delayed, and he was, remember this is in the late 1940s, early 1950s. There were essentially no anti-epileptic drugs available. Dilantin was just coming into use at that point. And it was known, same way I showed you before, that hippocampal sclerosis and hippocampal lesions could give rise to seizures. And the group in Montreal, Wilder Penfield and his colleagues, had shown that if you took somebody who had left-sided seizures, left hemispheric seizures, and you lesioned the left hippocampus, many of them stopped seizing. And this was becoming an established surgical practice. And so in 1953, at Hartford Hospital, a neurosurgeon named Scoville operated on him, but because HM had seizures that were bilateral, sometimes they were on the left and sometimes were on the right, Scoville lesioned both hippocampi. Okay? And HM woke up after his surgery, and he wasn't clear what he thought had been done. And as I'll show you, we now know a lot more about the anatomy of it. And after this, his seizures were in fact better controlled. They could actually be controlled on antiepileptics. He stayed on Dilantin for almost his entire life. He also then had a complete anterograde amnesia. So what does anterograde amnesia mean? Forward going, which lasted forever. So he basically was unable to generate new memories from this point forward. So what does that tell you? What did you need to make those new memories? You needed something that was in those two things that got lesioned to have been working. He had his older memories. There are interesting papers that are published where he's able to sketch out the layout of the apartment he lived in when he was 10. So what does that tell you about those memories? Yeah, they're someplace else, okay? So that there's something about the encoding of new memory. His language was intact, in almost completely in lots of ways, still subtle issues. But all of the ability to generate new memory was lesioned. He was studied by a whole variety of neuroscientists, most prominently Sue Corkin at MIT. This is actually a paper of hers from 2002, highlighting all of the impact that studies of this one individual had on our understanding of memory. And I'll highlight at least one of them that comes back to this issue of motor memory. So normally when you do a task, you improve on it. So if I ask you to do something, if I give you the task of, I put your hand under a shelf so you can't see your hand, and you're trying to trace, you can't see where your hand is, and you're trying to trace a mirror image of a drawing, okay? So you're doing mirror image tracing. First time you start to move, you look at it, and you know the line goes to the left. So you try and move your hand to the left, and in fact your hand should have gone to the right because you're looking at the picture in the mirror. And over time, what happens? You get better at it. You actually compensate and begin to go, okay, look, the line is to the left, I move to the right. Okay? You do that. When HM was tested on this, so most people, in fact, show improvement, reduced errors if you do 5 trials on Monday, 5 trials on Tuesday, 5 trials on Wednesday, and so on through the week. And you can show that people improve. Okay? HM was tested with this. And what do you think happens? Comes in the first day, they explain the task to him, and he performs as poorly as just about anybody else. What happens by day 5? Comes into the room. Does he know what he's supposed to do? No, they have to explain the task to him again. But he has operationally gotten better. Okay? Because that is not either semantic or declarative memory. That's not declarative memory. Okay? These are scans, so eventually in the early 90s it was decided that he could get put into an MR scanner. The issue being that nobody knew whether any staples that had been used in his neurosurgical procedure would have magnetic susceptibility. Now, those are not, all of those staples are do not have magnetic susceptibility. They create some artifact, but you don't have to worry about them heating. And no one had the records from Hartford Hospital, so they got through a whole long search to find out what was used in surgical staples in the U.S. that were available. They finally convinced the IRB that he could be scanned, and he was scanned, and one could see what's missing. So what's missing? Okay, anterior hippocampus. What's missing here? Where are we? What level? Pons. So you should see medial temporal lobe here, anterior medial temporal lobe, right? It's not there. What's underneath that? What should be underneath that? Hippocampus. Okay. HM actually died now a bit more than a decade ago. And at the time he died, That's him there. His family identified him. So he'd been known in the literature as HM always. His name is Henry Molaison. Wherever it is. Here it is. So the family identified him as an obit on the front page of the New York Times to reflect the level of importance that he has for sort of cognitive neuroscience and understanding of memory. Remarkable. He came, he got autopsied. This is him. This is an overnight scan in the scanners in the Navy Yard for a postmortem scan, and you can actually see where the anterior hippocampal resection has been. What else do you notice? Yeah, so louder. Yeah, it's really small. So this is a consequence of 40 years of dilantin. So dilantin leads to cerebellar atrophy if it's used over time. It's not very much used anymore as an antiepileptic. It has this plus gingival hyperplasia, sort of gum proliferation. But this is end-stage cerebellar degeneration as a consequence of his long-standing dilantin. What do we know about cerebellar function, especially the inferior portion? It contributes to cognitive function in ways. Okay, so it's a confound in some of his later studies. This is HM's brain at autopsy, which I did. What can you see? Okay, no one else gets to see these. Okay, what do you notice? What do you see? You can actually see the scars. So here, what is this? Temporal lobe, here. Olfactory bulbs. Optic nerves. Chiasm. Third nerves. 2 blood vessels. Here's his basilar. Why is it yellow? Atherosclerosis. He's 81. Okay? What do you see here? Look at this. Here's the third nerve. What's that vessel? Where is that vessel? So here's the third nerve between 2 blood vessels. So this is superior cerebellar. This is posterior cerebral. Here, this is posterior cerebral, and right there, coming out over here, is superior cerebellar. Okay? This is vertebral, other vertebral. Come back to the other stuff later. But here you can see this is the lesion that was made. It was made by reaching in underneath the frontal lobes, basically with a blade, and cutting and vacuuming out tissue from right here. If you actually look at the images from this, you can now actually map out his anatomy. And for people who are interested in this, you can see that posteriorly, his hippocampi, there is some hippocampus present, okay? But what's this structure right here? Fornix. It's tiny. Why is it tiny? Most of the hippocampus is gone. What generates the fibers that are in the hippocampus? In the fornix? The hippocampus. Those of you who are interested, this is Gene's paper on the hippocampus and the anatomy of HM. And for anybody who's interested in reading about him and the like, I'd recommend Sue's book. Sue died about 3 years ago now. It may be longer. But she published this, got this finished right before, just a bit before she died. And it really does discuss it. There's only one audio recording of an interview with HM that was part of a PBS broadcast, an NPR broadcast early 2000s that I will put up on the link. And it's really interesting to hear him. So he's being interviewed by Sue, who's worked with him essentially for 40 years. And he does not know. He has familiarity, but he does not know who she is. And you'll hear him discuss what it is like and why he participates in research. It's really rather powerful. No, so a lot of that, so the immediate context, when we think about memory, there are multiple steps that are critical for it. The first is encoding it and being aware of what's going on, and that's not hippocampal. That's cortical. The long-term recall is not hippocampal. What goes on in the consolidation stage as you go from sort of, yes, somebody told me this, onward is hippocampal. And so there are lots of operational things. He moved multiple times from one care facility to another. He was able to do things like learn where the bathroom was. Okay? So there are pieces of sort of operational learning that are very outside of that. But the problem is it's very hard to know and ask the question, what did it feel like this morning when you woke up? Well, 5 hours, a couple hours later, he won't remember the experience of having woken up. It's really rather challenging. The other... So the first thing is nobody gets them on both sides anymore, ever since that. So Scoville actually reported it, and so nobody does it. So the consequence is if people have got, who are going to undergo hippocampal resection, the first thing that gets assessed is the quality of function on the other side. It does mean that somebody who's had a partial hippocampal or anterior temporal lobectomy for seizures is incredibly vulnerable to significant deficits from contralateral stroke. Okay, so that's a real issue. The other thing that neurosurgeons are very careful about is they navigate through the ventricular system surgically. So they can put basically a endoscope into the ventricular system, and you come in through the lateral ventricle, and where you're typically trying to get to is in the third ventricle walls, because it's otherwise really hard and dangerous to reach. But in order to get in there, you have to go through the foramen of Monroe. And at the foramen of Monroe, on the thalamus side, you're going to have the anterior nucleus. But dangling in the middle, you're going to have the fornices. And so the concern is if the space is not big enough that you can't avoid the risk of damaging the fornix. Because if you damage the fornix, the hippocampus can be working perfectly, but if you have essentially cut off its output, you have the equivalent consequences. So fornicial injury is another way that you can get the equivalent. But the first thing is that nobody gets bilateral hippocampal resections. So the other thing that was very obvious and clearly important about hippocampus in terms of its function is when people recorded from it in behaving animals, and anybody who's really interested in reading something sort of foundational in this field, I would recommend this book by O'Keefe and Nadell called The Hippocampus as a Cognitive Map. It's actually available as a PDF online. It's old, but it's brilliant. Put electrodes into free behaving animals, and you record from the hippocampus, and you're trying to figure out what's the circuitry, what's going on when they learn. Okay? We know we use it for learning. What was observed was that not only did it fire when learning tasks were being done, but as the animal moved around the cage, there were positions in the cage at which individual neurons fired consistently and positions where they did not fire. So here there are, 6 points identified in the cage, and every time the animal was in position A, there's neuronal activity in this unit. And when it's in other places, it's much less frequent. And when it's in B, which is close by, it's got a little bit, but the further away it gets and the further it's oriented in another direction, it's quiet. And these got called place cells, and people were able to show that if you put mazes in a rat. If you put rats in a maze and recorded that they had cells that fired in consistent patterns as they went through the maze and so on. And if you look at them in the hippocampus, they fire in a place. If you look at the input to it, the entorhinal cortex, they fire in a grid. So that you go from a grid structure in the entorhinal cortex and input, and any point in that grid will then clearly be pointing, so this piece of the hippocampus here corresponds to just this part of that grid. Why do you have a grid? Because the grid, this entorhinal neuron is sensitive to any one of those grids, but this part will project to this one will project to some other part in the hippocampus, and this to another, and so on. And then what about the gaps in here? Well, other entorhinal neurons cover these grids. And so you've got this interwoven packing of grids that go to interwoven, interlaced space map in the hippocampus. Okay? And these do exist in humans. So how do you do this? Do you shove electrodes into the hippocampus and tell some volunteer to go wander through the maze and record things? Yeah, you could. It's really hard. Humans, for the most part, don't like walking around with a pedestal on their head hooked to wires in the ceiling, which is the way these rats work. So what was done instead was to, in people who are undergoing functional neurosurgery, so neurosurgery to either create lesions or resect hippocampus, to put electrodes in there, and meanwhile, give them essentially virtual reality and have them walk around the maze while they're lying on the operating table, okay? And then you can discover that, in fact, depending on where you are recording, if you look at the patterns, you can find grid cells and place cells in humans. So this is not a rodent-specific process. This is what got the Nobel Prize in 2014. This is O'Keefe, and then these are the Mosers, who were the other two people. Nadel was a grad student of O'Keefe's and was not included. Don't need the volitional movement. It's about spatial context. And if you actually feel you are in the right place, it's not about distance walked. It's about where you are. And so where you are is based on your cues, and if your cues are coming from virtual reality, they are your cues. So it's not that you are keeping track of 14 steps forward, 3 steps to the left. You know, the first 14 cells fire as you do steps forward, then you have a set of steps that fire to the left, and they've sort of marked you someplace. It's all about the context. Place.
I'm not sure I understand if the internal cortex is a grid, which you map different spaces in the hippocampus. How is the hippocampus not just a grid, too? It's just different ones map different spaces.
Because a hippocampal neuron only gets input from one point on that grid. So for any place in space, a grid says in a fixed place in space, multiple cells in different places respond. A place cell says in one place in space I respond.
Oh, so are all those grids going to that place or no?
What?
All those ones
No.
activated in the grid are not going to that one place?
Not all going to that one place. Because you have multiple grids. All right. So we know if you use, and this is back to Kike's question, we know if you use landmark recall, if you are using fixed points to navigate, you activate the hippocampus. And the most of these studies came from Verkowiak in London, and he had at that time a unique set of subjects. So in the pre-Uber era, taxi cabs in London, unlike in any other place in the world where the taxi cab driver has no sense of local geography and is as lost as you are, okay? In London, taxi cab drivers, the black cab drivers, were required to basically pass a test, which required them being given a starting point and a finishing point, and being able to, without looking at maps, but without doing anything, recall the most effective route to go from place A to B. Okay? And those of you who've spent time in London know that it is not necessarily the easiest place to navigate. It's not like Manhattan, where you can follow a nice grid and go, well, I'll go, I'm on 74th Street and 1st Avenue, and I need to be on 85th Street and 3rd Avenue, so I will go up I will go up 1st Avenue to 85th Street, I will go across, and I will be there. It's not got a grid, so you've got to navigate a map. And what was shown was that during that sort of cognitive navigation, not driving, but thinking about what your route would be, they activated hippocampus as opposed to other people who did not have the training. If you look at controls, the hippocampal volume is actually larger in these subjects. And that raised the issue, is this a pre-selection process? You're only successful in doing this if you have a big hippocampus. Okay? So maybe that's maybe like genetic risk or genetic predisposition. Maybe only people who can pass it get to that. So instead, what was demonstrated was that, in fact, if you look at the length of time people have been doing it, hippocampal volume, especially right-sided hippocampal volume, grows. So here, this is, as you do the change, so this is the x-axis in here is time as a taxi driver in months, okay? So that the more you do this, the bigger it gets, okay? So, you get in a cab with a driver without a hippocampus? There's a paper. I will let you go find it and read it and see what it says. But they took an enormous advantage of this incredibly skilled population who they could compare to controls. Regular drivers in London represented their controls. Okay? So they are an enormously interesting matched group in that sense. Okay. We will close the hippocampus. All right. I'm clearly not going to get all the way through amygdala today. So we will clearly leave some of it for Friday. And we may ripple a little bit of some of Friday into Monday. But we're okay. So let's think now about amygdala. And the reason it's grouped is a bunch of things. One is it's next to it. Okay? So the amygdala sits anterior and superior to the hippocampal formation. It's separated from the hippocampus by that anterior portion of the temporal lobe, that seam of the temporal lobe. It's very complicated within it, but we will basically break it into a couple of divisional things. But the other reasons that we think about it together is that it does and has wiring that is parallel. Okay? It's actually going to gather information from a wide range of sources and project out to a wide range of sources. Unlike hippocampus, where most hippocampal input is really very narrow. It's really from entorhinal cortex. And its output is really very narrow. It's out through that fornix, okay? And it's out mostly to just a few targets. Precommissural fibers into medial septal and accumbens, and postcommissural to mammillary bodies. So that's not the parallel. But what is the parallel is this loop, okay? So we make that loop of the fornix, and we will see the loop of the stria from the amygdala. All right. It's also important because they are wired closely with each other because the memory content that the hippocampus brings to the table speaks very heavily to the fear, emotional, and assessment value that the amygdala brings. So where are they? So these are the same pictures that we've seen multiple times, but let's think a bit about that anatomy. So what is, let's come up here. This is lateral ventricle. This is third ventricle. These are fornices. There's basically no way if you're a neurosurgeon trying to shove an instrument from the lateral ventricle that you'd get into that third ventricle without pushing the fornices out of the way. That's a bad thing. So they wouldn't do that in somebody like this. It's mostly done in the setting of obstruction so that the opening of the foramen of Monroe is easier. So that the pathology, in fact, gives you access. But sometimes it doesn't. Okay? So then what's this right here? Lateral ventricle, what part? Temporal horn. Why don't we see it on the other side? Is there some problem? Well, what can you tell me about the two sides of the cut? It's a little challenging, but I think you can figure it out. Are they at the same level? That's a good answer, right? Because they look different, so they're probably at different levels, or there's probably some local pathology. So now, which one is anterior and which one is posterior? It's a crooked cut. So which side is more anterior? Left. So what are the landmarks you're using? Yeah, coin, right? So one would be caudate. That's a little tricky to sort of see. Maybe there's a little bit more caudate. But how about, what else can you use? So you can use the lateral ventricle. I mean, we're trying to figure out why there's no temporal horn, so maybe that's the reason. But how about, what is this? Thalamus, what nucleus? Anterior nucleus. Do we have the anterior nucleus on the other side? No, we haven't come to it yet. Okay? So we're not at the level, so that suggests that it should be more anterior. Then we look over here. So if you look here, we've got, this is what gyrus here? Parahippocampal gyrus. Here we can begin to see the hippocampus folded, right? Do we have hippocampus here? No. Instead, we've got this big lump. What's the big lump? Sort of look like an almond to you? Should. What amygdala means. Okay? That's the amygdala. On this side, you can see the amygdala is here. But most of it, if you look, it's deeper in. That's the curved surface of the amygdala behind us. Okay? So here we're just skimming the posterior boundary of the amygdala, and here we're still in the middle of it. It is anterior, as seen on this side, and superior to the hippocampus. Right here on the hippocampus, what about this white matter? What is that the very beginning of? The alveus, the white matter that sits on the surface of the hippocampus, that's going to become the fimbria. You see it if you are standing in the temporal horn looking medially. If you put your body here and look in, you will see the alveus. And in fact, when neurosurgeons go and do open hippocampal resections, what they do is they cut through the middle and inferior temporal gyri here to be able to get to this spot, and then they can see hippocampus and grab it, and they can see amygdala and grab it and resect them by going from the lateral surface. Okay? So anterior and superior to the hippocampus. Now where is it? Can you see it? So this is, okay, this is hippocampus. Notice, anybody, I don't think I mentioned this. What do we call this part of the hippocampus? It's got these little toes. It's the pes, the foot of the hippocampus. So it's the pes. Okay, as in pedestrian, walking on foot. This is lateral temporal horn of the lateral ventricle, and this anterior and superior is amygdala. If I asked you to tell me what you thought this part out here might be called, is it lateral? Yeah? Is it superior or inferior? Inferior. So it's in fact called basolateral. How about this portion over here? It comes right up against the cortex and is medial. Corticomedial. Okay? What are these? Heading to the mammillary bodies. So those are the fornices. And as I said before, the hypothalamus sits right here. And we're going to have fibers that go from amygdala to hypothalamus. So how would you think they're going to get there? And some of them actually do take what looks like that straightforward, nearby, simple route. And we call those amygdalofugal. They're going centrally. Okay? But many of them will follow a far more complicated course. Oh, look at that. I labeled it. Entorhinal, pes, and the amygdala. So when we think about it, and we think about the corticomedial, the so-called central, and basolateral that I tried to sketch out there. Okay? There's far more substructure to it. You do not need to worry about it unless you are going to be an amygdaloid physiologist. Okay? But basically, in many ways, we think about the flow in the basolateral to corticomedial, but not always. We'll come to this when we talk about function later. So, these are incredibly widely connected. Okay? And that's because we're going to use our amygdala to make decisions in part about should we respond with panic or should we accept? Okay? Basically, panic is an incredibly important decision point in animal survival. Okay? Is this dangerous or not dangerous? Is key to survival. Okay? You misjudge that, lots of other things don't matter anymore. Okay? Not recognizing danger is really problematic if you want to think about evolutionary success. Okay? So, what do you need to do in order to recognize danger? What do you need to be aware of? Everything, right? You need to be aware of everything in the environment around you. You need to be aware of everything going on internally. And you need to be aware of context, memory. You need all of those things for input. And as we'll see, almost all the cortical areas, especially higher order association areas, project and connect to amygdala. Okay? Why wouldn't primary motor cortex project to amygdala? Where does that sit in the chain of sort of conscious decision? It's an output effector. Okay? So, I mean, at that point, if you're going to be contracting and using motor cortex to drive anterior horn cells to contract muscles, you've already made the decision at the amygdaloid level. Okay? Similarly, you don't want just the immediate first-order somatosensory information. You need that information after you've made decisions about it. So primary sensory cortices don't come into the amygdala and don't connect back and forth with it. You want the highly processed. Where does that highly processed live? In all that homotypic cortices in the prefrontal areas, parietal lobe, and temporal lobe. So those are incredibly tightly wired in. And the connections are mostly out back to cortex, and then through hypothalamus. And as we'll see on Friday, hypothalamus drives not the somatic, but the autonomic outputs that always travel with our somatic outputs. So when we think about them, we can think about an enormous range of inputs. And they're complex here, but they're simplified in a lot of ways. We think about olfactory. Okay? The olfactory bulb comes in. It doesn't go through thalamus. It comes to cortex. The piriform cortex sits right above the amygdala. And one of the projections goes from piriform down to the amygdala. Okay? The evocative sense of smell is that power of it is mostly from the inputs into amygdala. We'll talk about the hypothalamic connections on Friday, but we have connections from prefrontal cortex, cingulate cortices, temporal lobe, parahippocampoid gyrus, insula, and all that come in to the amygdala. Okay? We also have fibers that are coming from the so-called from hypothalamus. So there'll be projections that come from hypothalamus into amygdala by that nearby loop that comes, if we think about the walls of the third ventricle here, with our hypothalamus here and here, like that. And we've got the connection out into the medial temporal lobe where the amygdala sits like this, right underneath the parahippocampoid gyrus. Okay? There are connections in both directions that run in that amygdalofugal pathway. But there are also fibers that run from the hypothalamus through the stria terminalis. Many of them will synapse in a nucleus in the stria, known as the bed nucleus of the stria, or BNST. And those project, look at this, is that ugly sort of loop back to the amygdala. This is the same trajectory as the fornix. It's an arc. Hypothalamus back all the way superior posteriorly and then way medial back up into that medial temporal lobe. But what's different about the stria? What have I just shown you? Which way is it going? It's going into the amygdala. Which way do things in the fornix go? Out of the hippocampus. Okay? And as I'll show you, the things in the stria they're bidirectional. Their axons run in both directions. There's input and output. Whereas in the fornix, it is vastly, vastly, vastly output predominant. Okay? Comparable arc-like trajectory, though. So when we think about the outputs, the amygdala is reciprocally connected back to those cortical areas. It is connected to accumbens, and we'll talk about that on Friday clearly. And it is connected to hypothalamus. And we know hippocampus is connected to the amygdala. Hippocampus is also connected to hypothalamus. What part of hypothalamus? The mammillary bodies. Mammillary bodies are part of the hypothalamus. They're part of those hypothalamic landmarks. Okay, so those outputs go in both ways. They go by that sort of shortcut so-called amygdalofugal pathway, and they go to a variety of structures who we will cover in the next 2 lectures. But those are basically things that are medial, hypothalamic, and immediately adjacent structures. Okay? So that's that short loop. There is also the output loop that goes through the stria terminalis and comes around. And it makes a loop that goes just like the others. It splits at the commissure. Lots of them come anteriorly to those same targets, nucleus accumbens, septal nuclei. Some go posteriorly, but instead of going to the mammillary body here, which is a hippocampal target, they go to other hypothalamic areas. Okay? So we've got our memory content coming to our hypothalamus, and the emotional valence content coming to hypothalamus. When we think about those pathways, we've got the stria terminalis and the fornix, both of which make that loop. The difference is that this is bidirectional and this is output directional. Okay? So that's the stria terminalis. What's the lamina terminalis? We talked about that? We mentioned the lamina? Maybe not. Yeah, it's the anterior wall of the third ventricle. We'll talk about it more on Friday. Okay. I can skip. This is just trying to get you to see it in the other orientation. It basically makes the same arc as the fornix. So when we think about them, if we think here in the dotted line, you can see that amygdalofugal pathway, here called the ventral amygdalofugal, right from here to there. The hippocampus is going to be here. Here's the mammillary body. But there is no hippocampofugal pathway. This doesn't exist. Instead, the hippocampus runs all the way back and comes back to the fornix that's going to come down there into those mammillary bodies. So the fornix is there from hippocampus. The stria terminalis sits right on the surface here and is running from the amygdala to the comparably adjacent targets, in addition to that amygdalofugal pathway. Okay? We have some fibers that go directly down. And in a sense, the things that are going to drive your descending autonomic are the fast ones and the short pathway. So the more likely outputs are, the more outputs are that go through the amygdalofugal, they're going to drive descending, whereas those that are going to other areas through the stria terminalis are going to be going ascending. That's how you get back to the cortex, not directly, but by indirect synapses. Okay? And the cortical, as I said before, are skewed. So let's finish up with a few moments on what the amygdala does. It's really important in the modulation and response of fear. So abnormalities in it, and there are a variety of ways that this can happen. Some of them are disease-related, others are not, leads to loss of fear and anger, increased exploration, increased hyperorality. So the classic example is there are a series of mouse experiments where either lesions were made or genetic manipulations were made to disrupt amygdaloid function. And you get these mice where you put them in a large open environment with a cat. And the mice go wandering up to the cat, sniffing it. They have absolutely no contact, as opposed to normal mice that basically, make themselves as small and invisible as you can possibly imagine. All right? So, the amygdala sits in this place between all those cortical areas that we've talked about, okay? That include the things that have processed memory, perceptual memory, working memory. It's connected through hippocampus. It's connected, in fact, through the striatum, most specifically through the nucleus accumbens. And we're going to deal with outputs that way. Now, probably everybody has had this experience, okay? You sit in a parked car. You've gotten into the car. You're sitting there parked. And you hear the police siren, okay? What happens? Okay? Your heart rate goes up, okay? Just for a second or two. But your heart rate goes up, and then you realize what? It's probably not me, because I'm sitting here in a parked car. It's probably somebody block away who went through a red light or did something else. And what happens? Your heart rate goes down, okay? But what made the heart rate go up? And why did it go up before you processed what was going on? So what happened when you heard that siren? Let's start at the basic level. Where'd you hear it? Okay. Probably first in one ear, and then slightly later in the other ear, so you were able to spatially localize it. Using your superior olivary complex, fibers came up through lateral lemniscus, inferior colliculus. Next. Medial geniculate. Next. Primary auditory cortex, auditory association cortex. You're able to take that frequency map, turn it into sound, sort of complex sound again. You're able to hear it. Where does it go from primary auditory cortex? Secondary auditory cortex? Just sits there? Now, what does it do? It'll go out into your parietal lobe. It'll come to your frontal lobe. And at some point, your frontal lobe is going to say, don't worry, you're sitting in the parked car. Okay? That depends on your context. You have to know where you are. Okay? But along the way, that sensory thalamus turns out to project also into the amygdala. So that you actually have an incredibly quick response driven by the amygdala, which says, novel potential threatening stimulus, respond, and your heart rate goes up. Okay? And as that heart rate goes up, that's the amygdala talking to hypothalamus, hypothalamus talking to the descending autonomic control that does what? What does it do to your vagal tone? Up or down? Down. Turns your vagal tone down, turns your adrenergic innervation of the heart, which is a little bit by synapse and a little bit more by adrenal medulla, up, and your heart rate goes up. And when you're ready to turn it back down, you just turn the vagus back up and quiet it goes. Okay? And that happens first. And then the amygdala hears from the cortex, don't worry, you're in the parked car. Okay? So it sits as an intermediary. It is attuned to potentially threatening stimuli early to give you the quick response before you have to process about context. Okay? All right. And so here it sits, and we'll talk about some of these other structures when I get to talk more about this on Friday. But basically, when we think about our hippocampus, okay, we have hippocampus, which goes to the hypothalamus. That hypothalamus projects from the mammillothalamic tract to the anterior nucleus of the thalamus, okay, and that comes up to cerebral cortex. And specifically, what part of cortex? Anterior nucleus? Cingulate. Okay? How about the thalamic output component for amygdaloid responses? So they actually go directly from amygdala to thalamus, and they go mostly to dorsomedial. And where does dorsomedial connect to? The prefrontal regions. Okay? So that you're really using it for that modulation of response. What is my context? What am I doing with it now? Whereas that hippocampal circuit is interacting, but the hippocampal circuit is like remembering, okay, that's one more time that I heard the police siren. Okay? That's just filing that away under an episode. What you're doing with your prefrontal back and forth to your amygdala, because remember, it's going to go back and forth, is, in this setting, I need to worry about it less than if I am driving and I know I just went through the red light. Because you went through the red light and you hear the siren, your response is very different than when you're in the parked car and you hear the siren. All right, let's stop at this point, and I will pick up and shift the remaining portion of this into the discussion on Friday when we think about the hypothalamus. Because we're really getting into that fuzzy zone of what is amygdala function and what is hypothalamus.